Good evening, everyone, and welcome to today's session. This is Dr. Murli Bharadwaj, your classmate in NEET PG and FMGE preparation. So, most of you guys have seen in the most recent NEET PG that a lot of clinical Vignette based questions. The biggest paradox of our times is all our medical school training is like Africa, whereas our exams are like America. So there is a huge expectation of the examiner that we perform a lot of clinical Vignette based questions. So I thought, let me help you to become professionals in answering the clinical Vignette based questions for the NEET PG exam. Let us say we have a question. Good to see a lot of our online classmates. A woman presents to the emergency labor room because of abdominal pain. It began about 2 hours ago. She is in her 34th week of her pregnancy. When the pain has come when she is on dinner, she also noted a clear rush of fluid that came from her vagina. The patient has a past medical history of depression, which is treated with cognitive behavioral therapy. That means she is not on any medications as such. The temperature is 99.6 degrees, which is fairly a normal temperature. Her blood pressure is 127/68. Pulse is not a very severe tachycardia, of course 105 per minute, slightly on a higher side. Respiration is 19 per minute. Oxygen saturation is good enough. And you have noted a young, healthy woman who is complaining of painful abdominal contractions, which are occurring every few minutes. The laboratory studies have shown that her hemoglobin is 13, that is, she is not severely anemic, and her leukocyte count is 5,500. That means she is not having any significant infection. Platelet count is 237, which is, that means she is not having any HELLP or any thrombocytopenia, DIC or anything. Her sodium chloride, potassium, vagera, so many things are being given so that the examiner allowed to waste your time. Ultimately, her lecithin sphingomyelin ratio is 1.3. This is the most significant finding. So when you have a clinical Vignette based question in the NEET PG exam, you should know where is the clue. You should hunt for the clue, right? The clue is in her lecithin sphingomyelin ratio. It is about 1.3. So what is the next best step of management is the examiner's question. Very good to see Hero online. Absolutely. Premature rupture of membrane. I hope the voice is loud and clear for everybody, and you're all online, I hope so. Please mention your classmates. So please don't forget to click on the bell sign while you are subscribing on youtube.com online MBBS. Because whenever I start an extempore class like this, you get a notification, right? Now, what is the best next step in management? Do you like to give betamethasone? Do you like to give Rogam, oxytocin, terbutaline, expectant management, etc., etc.? Good to see Vivek Kumar, Shweta, and many more who are all online. Now, doctor, what this patient is having is absolutely right. Premature rupture of membrane. prior to 36 weeks. Lecithin sphingomyelin ratio less than 2.0 is a very important clue. Examiner, the NEET PG examiner want you to briskly to look into the clinical Vignette and recognize. And she need to receive the betamethasone for the fetal lung involvement. So betamethasone is given to all the patients who are before 34th week. This is very important, doctor. Examiner is going to be very sure and specific. Similarly, in any case less than 36 weeks of gestation with a LS ratio less than 2.0 or less than 34 weeks of gestation. The LS ratio suggests the fetal lung maturity and it is supposed to be more than 2.0. And for patients with the LS ratio less than 2.0, your main intention of giving the fetal, steroids is to accelerate the fetal lung maturity. Now, why not terbutaline? Come on, let's have an argument. Why not terbutaline? Terbutaline is a beta-2 agonist, tocolytic. In this case, tocolysis is not really necessary, right? So, because she has a painful abdominal contractions that occur very few minutes. That is an important point of the clue. Then oxytocin, do you want to give? No, it is for augmenting the labor. So that is the reason you don't need to augment her labor. Then Rogan, but if she is a RH negative mother and the fetus is RH positive, then she needs to receive a Rogan in this kind of clinical situation. When you want to do expectant management, a lot of times the women come rushing to the emergency saying that they had a gush of amniotic fluid. You can give expectant management, but if the LS ratio would have been more than 2.0, but in her case, the LS ratio is how much, doc? 1.3. That's the most important clue for you is what you should recognize. So, the bottom line of this entire clinical Vignette in the NEET PG examiner is trying to check with you is, do you know the fact that to accelerate the fetal lung maturity, you need to give the betamethasone if the lecithin sphingomyelin ratio is less than 2.0. Once upon a time, they used to give single liners. Of course, today single liners are very much there in the NEET PG exam, but examiner is trying to make it more of a clinical story. So are you all ready? Let us learn 20 points about preterm labor before we all become experts. So doc, now let us learn about the preterm labor. Good evening. I hope you are all able to see the cam, right? It's visible, right? Now, first point. Today I have a great mood for spending a good amount of time with you guys. Yeah. Yes. With a little bit of handwritten stuff. Expected date of delivery. How do you calculate? What is the rule called as? Neglis rule. All of you know very well. Good to see Vijay Bhargava Pasupuleti. Now, second point. In case of term pregnancy, you need to be very sure to define when do you call early term, full term, late term. You call early term if it is 37 to 40. You call it as full term if it is 40 to 41, and you call it as the late term or post term if it is 41 to 42 is what you need to remember. Barabar? Now, typically preterm, the definition of preterm is 24 to 37 weeks. In India is very special country, right? All Indians are my brothers and sisters, and my preterm laboring women are all my special sisters. In India, the definition is 24 to 26. Please don't forget. WHO definition is anything earlier than 22, but in India it is 24 to 26. Now, when do you call late preterm? There is one more variety, doctor, that you need to remember. When it is 34 to 37, you call late preterm, and before 24 to 34, it is early preterm. That's what you should remember. Then moderate early. There is one more term like rava dosha, right? Masala dosha, onion uttappam. There are so many varieties, doctor. So it is 32 to 34 weeks. And very early preterm, what is the definition? Examiner will try to catch you only on these important numericals, doctor. 28 to 32 weeks is called very early preterm. When do you call extreme preterm? When do you use that word extreme preterm? When it is less than 28 weeks. So these are a few definitions which you have to be very clear about. Barabar? Now, the next important thing is, how are we going to define the preterm? We should remember cervical dilatation is a very important clue. If the cervical dilatation is 1 to 3 centimeters, right? We call it as early preterm. Then if the cervical dilatation is more than 3 centimeters, you call advanced preterm. Barabar? Then one more important thing is cervical incompetence. How are you going to define cervical incompetence? Typically, when the cervical length is less than 2.5 centimeters in the ultrasound, and there are no contractions, that defines the cervical incompetence is what you have to ultimately remember. Then there is something called threatened preterm. You should know. Threatened preterm. So how do you define threatened preterm? So basically, you call threatened preterm. Do anybody know what is threatened preterm? Can you please punch in the chat window, doc? Make it an interactive session, right? So every day we will be springing with a lot of PowerPoints, etc. Suddenly what I understood is, we should be a little more natural to what our school days. Just like two classmates sitting together and studying together. How do you like to define threatened preterm, doctor? Who is going to give me the correct answer? When do you call threatened preterm? Suppose if there are fetal contractions with no cervical dilatation नहीं हुआ, fetal contractions are there, then you call it as threatened preterm is what you should remember. Now doctor, a very important point about what are all the causes of preterm. Causes of the preterm is a favorite question of the examiner. There is one easy way to remember the causes. We call it as, what is meant by preterm? Term means full. Pre means it got diminished. So remember, diminish, D-I-M-I-N-I-S-H is the buzzword or rather a mnemonic to remember the causes. D is any distended womb, doctor. Distended womb. So what will distend the womb? There can be multiple pregnancy, there can be polyhydramnios, anything can distend. Barabar? I is infections can be responsible. Like bacterial vaginosis, then group B streptococcal infections, very common, typically in the maternal vaginal flora. Then any premature rupture of membranes or urinary tract infection, anything can be responsible. Then there can be some maternal causes. So what are the maternal causes that you can think? Preeclampsia, anemia can lead to preterm. Heart disease can lead to preterm. Antepartum hemorrhage can lead to preterm. Then low body mass index, any stress, depression, not getting seat in NEET PG can lead to development of preterm is what we need to remember. Then there can be iatrogenic causes which can lead to preterm. What is the most common iatrogenic cause that you will think, doctor? Wrong date. Most common, one of the very common reason, because of a wrong date somebody will be labeled unnecessarily as preterm. Actually it is term only, but calculation of the date went wrong. So that was the reason. Similarly, if there is any surgery that is being done on the cervix or on the uterus, typically that can be responsible. So diminish, we are talking about the causes of the preterm. Now what is N? Smoking, doctor, don't forget. Smoking. My camera will be going out of focus sometimes. So, nicotine, N is responsible. Then similarly, I, what is I? Can you think of a cause of I? That can be responsible, I. How is the interval between pregnancies? Interval between pregnancies is a deciding factor. A very short interval between pregnancies can lead to preterm. Then diminution. Yes means short cervix. Any short cervix can lead to preterm. So how do you define short cervix? Typically, if the cervical length is less than 2.5 centimeters, you call it a short cervix. Funneling on ultrasound funneling of the cervical os on ultrasound is called short cervix. Then H is any history of preterm labor. Preterm labor is what you should not forget. So these are the important causes, doctor. Diminish is something that you are not going to forget. So what is diminish? So the preparation for the NEET PG, doctor, there is no very big hush-mush about it. It's all a question of identifying 2 to 3 good friends who are ready to study with you every day. Take up a nice notebook, and nowadays all entrance books are very well written. So it's very easy to do a revision. And let me give you all a good news, a very popular demand that sir, we want face-to-face classes also, because we are seeing you on the YouTube since centuries together. Of course, I am actually against the face-to-face, but still to meet the students, to spend time with them and to know what are their real challenges, insecurities, at least once in a week, that's a thrill. So we decided to roll out from the upcoming January 26th. So from January 26th up to June 21st, there are 21 weeks. Then from June to November 30, there are 24 weeks. So the 19 subjects, every Sunday we have a face-to-face class in Hyderabad. In Hyderabad, live class, morning 9 a.m. to 1 p.m. Then 2 p.m. to 5 p.m. every day, every Sunday. So we cover the 19 subjects in 21 weeks, one cycle. Then once more from June to November 30, in the second cycle called winter cycle, we finish this. In 24 weeks, one more round of 19 subjects will be done. And also, you get an opportunity that this live class, when happening in Hyderabad, the face-to-face interactive live class in Hyderabad, it is also broadcasted live on the YouTube, so that you can sit in the home and also can be able to access the program. But it will only be broadcasted to the subscribed students into the onlineMBBS.com. So, but still our subscription is almost 80% cheaper than many other coaching opportunities. So take opportunity at a throwaway price to buy the subscription, annual subscription to onlineMBBS.com video library, and also actively participate in these 45 Sundays, morning 9 to 5 p.m., 2 cycles of revision of the 19 subjects happening from the Hyderabad. Now, doctor, you understood the causes. Diminish is something which you are not going to forget. Now, is there any way, a very common question asked by the many women, sir, am I going to have a preterm, is what the women ask. Yes, sir, there are some predictors. How will you remember predictors? Preterm, how will you recognize premature rupture of membranes? There is a gush and a flush of amniotic fluid. You can remember the same flush. Number 1, F for fetal fibronectin. Fibronectin levels are one important clue. Every day in and day out, these are all worked out in the obstetrical ward. You have to be very sure. The normal value is considered to be less than 50 nanograms per ml. If this thing is elevated, there is a great risk of development of preterm. Then L, length of the cervix is very important clue, doctor. Normally, it is expected to be more than 2.5 centimeters. Then U is the urine culture. And also you can take the high vaginal swab. That is another important clue. Then S is salivary estriol. So peculiar, right? Saliva कहाँ है? Premature rupture of membranes कहाँ है? फिर भी there is a relation between the two. If at all there is more than 1.8 to 2, if it is more than 1.8 to 2, it suggests the risk for preterm. Then H is HUAM, not HEMA, HUAM. HUAM means home uterine activity monitoring. Just like we physicians ask for a home monitoring for bronchial asthma, you monitor the spasm of the bronchi with a home monitor. Why not for uterus? Home uterine activity monitoring. These are the important clues and predictors for the development of the preterm is what you should remember. Now, doctor, let us talk a bit about the shape of the cervix. The shape of cervix on ultrasound. Right? So what is the normal shape of the cervix, doctor? Normal shape. T. Then when do you call abnormal if there is any bulging of membranes? So typically you know that this is the uterus and the shape is supposed to be T. But it can be Y, it can be V, it can be U, where there is a bulging. So there are the other abnormal shapes of the cervix on ultrasound is what you need to remember. Now, doctor, are there any immunological factors? Today everything is immunology, right? Everything is immunology. Are there any immunological factors which are responsible? Yes, sir. There is a interleukin 1 beta, TNF alpha, interleukin 6, interleukin 8, MCP1, prostaglandins, etc. Now comes a very important thing, doctor. You are all smart doctors. Examiner, इसी क्वेश्चन के ऊपर what is the next step of investigation? What is the next step of management? आजकल के NEET PG का रिवाज हो गया. Clinical questions. So remember, you are all smart guys of Dr. Murali Bharadwaj students, right? So you should not forget smart. So what is smart? Of course, all of you know, yes means steroids. So, betamethasone is the preferred one, betamethasone. But what is an important contraindication, doctor, for giving steroids? Always you should look whether there is any chorioamnionitis. before you give steroids. You are very enthusiastic, but you should look already is there any chorioamnionitis. If you add steroid to that, you are adding ghee. You are adding the ghee into the fire. Right? Now, M is max sulfate. So all of you know how does max sulfate function? It reduces the contractility and max sulfate also is considered to be neuroprotective. It also saves the brain. If the gestational age is less than 32 weeks. So it has got two advantages, max sulfate. Then SMART. SMART में A क्या होता है? Antibiotics is what you need to remember. Now doctor, there is one important thing that you should remember. When we talk about chorioamnionitis, preterm labor, we are talking about what? Group B streptococci, which are the part of the vaginal flora. So, the important rule is, any asymptomatic bacteriuria, symptoms कुछ भी नहीं है, asymptomatic bacteriuria, right? Or any premature rupture of membranes, you should aggressively treat. Penicillin and Clinda. You need to remember in order to treat is what you have to remember. Good to see Asper, who is online. Very good, doctor. Very good. So, with very short notice, I started this extempore session. I felt that every day we throw a lot of PowerPoints and then we run it like a gymnastics. But why don't I become a classmate and sit with you like a senior and study along with you and master the subjects. So SMART में क्या क्या खत्म हो गया? Doctor, steroids हो गया. M for max sulfate is over. A for antibiotics is over. Then what else? R. What does R refer to? R refers to a center with high level intensive care. Definitely high level intensive care, because even if you successfully managed the preterm, what is the challenge which is remaining? The preterm baby who is being born. So you need to quickly give a phone call. Tring, 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 tring. Hello, who is speaking? Yeah. Please keep it ready. Just now in the district headquarters, we have delivered a preterm and we are sending this nice baby to you. Take care. So a higher center with high level of intensive neonatal care, you should send the baby. Gotcha? Then T. Lastly, T, that is tocolytics. If you can stop the flood, you can still build the bridge. After the flooding started, bridge it by giving tocolytics. Acha bhaiya, what are the various tocolytics that you know? Right? वो भी खत्म करेंगे. So, classification of tocolytics. Right, doc? Tocolytics. So, once more, those who are all online, let me tell you, Doctor, we have started 45 Sunday, 9 a.m. to 5 p.m. Long-term coaching, face-to-face classes, starting from January 26th at a very throwaway price. See, if you look at many mobile apps, the video library, videos and all that, people buy with a lot of enthusiasm, they jump and buy. Hardly 10% of the people really consume them. Even if they consume, they don't know how to revise. So, what I felt is, there are three things. One is, we have 1,000 hours of video library, video lectures. Second, we are also live online broadcasting so that you have a convenience of attending from anywhere you want, high density broadcast. Third is face-to-face classes. Now from this year we are restarting face-to-face live in Hyderabad, only Hyderabad. Right? That to only 100 students. We can't accommodate, our classroom cannot accommodate more than that. And fundamentally, I'm not a believer of face-to-face, but still, a lot of students requested that, sir, after live online, maza aa gaya. Last year it helped a lot. So, we love to have that motivation by spending every week with you. So I said, why not? We too don't know any other work. 9 a.m. to 5 p.m. Right, Doc? So, in these 45 Sundays, it will be divided into 21 and 24 Sundays, 2 cycles. So, by June 30th, starting from Jan 26th, one round खत्म करेंगे 19 subjects को 21 Sundays में. Then there is a second cycle that is 24 Sundays up to November 30. And we finish one more round in this 24 Sundays. Of course, this is live broadcasted on the YouTube, but I request you that we wanted to broadcast it into the subscribers, those who have subscribed, for a throwaway price. We are very affordable, cost affordable. Almost we are 70% less costly than many other commercial coaching programs. So please take an opportunity to jump and subscribe. You get the online video library, you get weekend face-to-face live classes broadcasted. Then also you get many more classes which we daily broadcast live, but we are going to broadcast it underneath the membership page to all the people who have subscribed. So take a chance to call our helpline and subscribe. Now, Doctor, let us talk about the tocolytics. One of the favorite questions, both in pharmacology and obstetrics. All beta-2 adrenergic, what type of drugs? Agonists are tocolytics. Terbutaline, ritodrin, isosuprene, they're all what, Doctor? They're all beta-2 agonistic drugs, right? Tocolytics. Max sulfate, tocolytic. Calcium channel blockers, tocolytic, nifedipine, nicardipine. Then oxytocin receptor antagonists or tocolytics. What is the drug name? Can anybody tell me what is that oxytocin receptor antagonist used as a tocolytic? Drug का नाम बोलो और Poppins packet ले लो, right now. So in our face-to-face classes, if you correctly answer no, you will even get Poppins secret, right? You can tell your juniors. Murli Bharadwaj, live face-to-face classes, if you participate, no, you will also get Poppins. Yeah, who is going to give me the correct answer, doctor? Pramod Gurjar, Aspern, Vijay Bhargava and many more. What is that oxytocin receptor antagonist? उसका नाम क्या है? फटाफट बोलो. Etosiban is what you should remember. What is that drug called? Etosiban. Etosiban bans the contractions. Then prostaglandins are responsible for uterine contractions, no doctor? Prostaglandin synthetase inhibitors. They are also tocolytics. What are they? Indomethacin, aspirin, prescription liquor, Dr. Babu, ibuprofen, they are also tocolytics. Then nitrous oxide donors. What was the NEET PG 2020 question? Nitrous oxide produced from arginine. So you have to be very sure. NEET PG is easy to conquer, but this time NEET PG has shown it is not just single liners but also clinical Vignette based questions that you need to practice. Finally, halothane also, doctor. Halothane is also a very good tocolytic agent, is what you have to remember. But of all these tocolytics, doctor, मैं इतना बताया ना, beta 2 adrenergic agonist, max sulfate, calcium channel blocker, oxytocin receptor antagonist, prostaglandin synthetase inhibitor, nitrous oxide donor, halothane. Which is the safest? Which is the safest? Come on, punch your answer, doctor. Which is the safest of all, Dr. Babu, that you want to give to Basanti because she is having preterm labor? Come on, who is going to give me the correct answer? Interaction, most important. Nifedipine, calcium channel blocker. Nifedipine is the most preferred tocolytic is what you need to remember. Very good. Now, doctor, lot of times you know very well that whenever there is, what is that hormone which helps to maintain the pregnancy, doctor? Aspirin is clean bowl. He thought max sulfate, but max sulfate was not right. Calcium channel blocker. Now, what is the role of progesterone? Role of progesterone is a very important point. Typically, if there is any history of preterm labor, prophylactically, because she is a high risk case, before this lot of preterm deliveries happen, for her you can give progesterone. but not useful if there is any active preterm. That is the point you need to understand. Got it? Now the next question. Cervical incompetence is one of the important reasons leading to the development of the preterm. Is there any role for encirclage? Is the examiner's question. So you should remember, doctor, there are certain indications to do that. Number one, if there is any previous history, that is the kind of Indian English. History itself is previous. ऊपर से previous history. अरे come on, हम तो उर्दू मीडियम में पढ़ाई किया. Anyway, Indian students, Indian teachers have a Indian English, right? Previous history of preterm birth. Preterm birth. We used to have one professor, she did MRCOG, पूरे लंदन में रह के आए. कभी भी previous history means she used to be she used to be very unhappy to listen the word previous history. So she used to say, future tomorrow I am going to fail you in exam. Future tomorrow. Tomorrow will be future only, right? If we say previous history, she used to say future tomorrow I will fail you in the exam. So preterm birth, or if there is any history of second trimester losses, then there is a role for encirclage. Similarly, whenever less than 28 weeks pregnancy, if it is there, that is another indication. But to do the encirclage, what are the contraindications? When you should not do? If there is any premature rupture of membranes, you should not do encirclage. Chorioamnionitis, you should not do encirclage because you are worsening the infection. Twins is a contraindication for encirclage. Antepartum hemorrhage, where very closer to cervical os, when there is a implantation, or any cause of APH is contraindication for encirclage, is what you should remember. Then what are the other choices available for you? There is a transabdominal encirclage, and Shirotkar's method of encirclage, which you have to be very sure about. So this is the story of the clinical Vignette doctor. All this funda, if you are good with any clinical Vignette based question in the tomorrow's NEET PG, FMGE, you will be able to crack, doctor. So thank you so much for spending your wonderful time. Please don't forget to write your comments. Did you like the PPT kind of a presentation, or did you like a handwritten, slow going, but together reading, this kind of presentation? Which one do you like? Please write a comment underneath, and don't forget to tell your friends to subscribe, your juniors also to subscribe in onlinembbs.com, right? And now our new batch, 45 Sundays live face-to-face class and 2 rounds of revision, and the same time live broadcasted. Whenever, because of internship or anything, if you miss also, you have a live broadcast available if you are on duty. And this face-to-face live class is happening in Hyderabad. You can tell your if you are from Hyderabad, you can attend in Hyderabad. And if you are not in Hyderabad, no worries. The same thing will be live broadcasted into the onlinembbs.com, where you can comfortably participate and enjoy the session. Good night and enjoy a great time to boot camp yourself and get ready for the upcoming AIMS, PGI, NEET PG 2021 and FMGE exams. Good night. We'll once more meet up tomorrow. Thank you.